So this is about, ready?
Yep.
So this is about spinal cord injury and how to take care of the airway. Now, when we take care of the airway, there are a few things that comes in my mind. Okay. So when airway, you say na, airway is not putting the laryngoscope through. Na? Airway means a lot of things, which includes position, which includes equipment, which includes pre-intubation, which includes drugs, and after drugs, after intubation. So when you say intubation, there are so many things that come in on a patient. That is right from position to equipment, to pre-intubation, to drugs, and to after post-intubation. There are so many things that you have to look at when you are intubating such a patient. And especially this is one of those patients in which we just now discussed that we need to maintain the blood pressure to be on the higher side. It is that patient in which you need to have the MAP of more than 85 if it's a young adult. Most of the accident cases are young adults. So if young adults are there, your MAP has to be 85 up. Every time you get the MAP down less than 85, this patient will suffer spinal cord injury, will have a chance of spinal cord ischemia, which can worsen these patients very badly. Are you getting the point? If I'm going fast now, stop me, okay? Alright, make it slow. So first thing is position. So my worry is, if by any chance the patient has got a head injury, if he's got a head injury, okay, any patient that has got a head injury, you have to consider it to be a spinal cord injury unless proved otherwise. Unless proved otherwise, you have to consider this as a spinal cord injury. So if I'm going to intubate my patient of head injury urgently, I have to ensure that I'm doing something called as MILS, or manual inline axial stabilization. We'll come to that. Okay, it's important that we do that. Clear on this? Clear? So which categorizes those patients who you will take care of this? Any patient who has fallen from a height of 3 feet. Any patient who's got an all-terrain vehicle accident. Any patient who's got a bicycle injury. Any patient who's got a rollover in the car. Any patient who's been thrown out of the car. Okay, any patient who's got a head-on collision. Or any patient who's fallen from one flight of stairs. This is the definition in which you actually need to rule out a spinal cord injury. Again, I'll repeat this. Any patient who, if it's a road traffic accident, if he's had a head-on collision at 100 kilometers per hour, that speed is important. So a very severe high velocity trauma with 100 kilometers per hour, that is one. Okay. The second is that patient who has had an all-terrain vehicle. All-terrain vehicle मतलब वो जो ATVs होते हैं, ATVs, वो ATV से गिरते हैं ना, that is all-terrain vehicle. A patient with all-terrain vehicle has got a spinal cord injury unless put otherwise. Remember this. Any patient who's had a bicycle collision and thrown out. A bicycle collision and thrown out. A bicycle collision is dangerous collision. उसका speed का ये नहीं रहता. It's a dangerous collision. So bicycle collision and thrown out. That is the third. The fourth, if it's domestic, if he's fallen from one flight of stairs. One flight of stairs is supposed to be severe head injury and cervical spine needs to be ruled out. Okay, one flight of stairs. Other is falling from a height of above 3 feet. Above 3 feet. Just this much height falling also is a significant head injury. Clear? So these are the category of patients where you need to be certain that the spinal cord is not injured, and that's why you need to do an urgent certain CT cervical spine multi-detector CT scan of the spine to understand whether the spine is injured or not. Clear? Clear on this till now? Apart from this, those patients who cannot neurologically obey your commands, those patients who have got severe head injury, the GCS on the lower side, those patients who voluntarily does not obey your command, does not move your head, those patients who never been mobile from the scene of accident, those patients who are sitting on a chair after the accident, unka problem nahi hai, who are sitting on a chair, or anytime they were mobile after surgery, after the accident. For example, there was a road traffic accident. The history is he got up, walked and sat at the side of the road. That person does not have a cervical spine problem. Mostly. You're getting the point? He's got up and off. So any time in the middle of the if he gets up after the surgery, after the accident, he gets up and he walks, that patient may have a less likelihood of having a cervical spine problem. So those patients who are intoxicated or pharmacologically given sedatives, those patients also you have to be taking care of their cervical spine. Who are intoxicated and who have been given some pharmacological drugs, they also have to be taking care of cervical spine. So you have to understand the indication where you have to take care of cervical spine. Clear? Indications where you have to take care of cervical spine. That's the first thing. Okay. So when they come for that matter, the problem with a high cervical spine cord injury is that you lose the accessory muscles of respiration, you use the intercostal muscles, you use the external intercostals, and more importantly, if the level is above C3, C4, you are actually losing the diaphragm. Okay, that means these patients have got a very high chance of just arresting. Remember this, if he is breathing less, okay, it doesn't immediately arrest. It takes a long time for them to arrest. He's breathing less. Oxygenation, maintain. Carbon dioxide buildup is occurring. Carbon dioxide does not kill. Carbon dioxide बढ़ते रहता है, then they suddenly arrest. You understand? So by the time they come to you, they are in that situation where you have to intubate them because you can see he's hardly breathing. ऐसा दिखता है कि नहीं श्वास ले रहा है. So at that time, you are suspecting that's a cervical spine column involvement. You need to intubate these patients. Patients come with a collar in place. What do? So in that case, first of all, ensure that you put the highest possible oxygen you can before you prepare. Highest possible oxygen that you can apply. That means you use either HFNC or you use NRBM. The normal nasal prongs will give you not more than 40%. The normal oxygen mask will not give you more than 60%. The HFNC can be triggered to 100% and NRBM can be given to such people. Clear? Just take the phone. NRBM, clear on this? NRBM, HFNC, both of them can give you 100% oxygen. So in the pre-intubation area, you have to ensure that you are giving that patient NRBM or HFNC so that the oxygenation goes up quickly. The second thing you will do in this case is to start an IV fluid and NORAD. Start an IV fluid and NORAD because you know there is going to be a drop in blood pressure. You don't want to be last moment doing things. So my thing is, if I'm suspecting cervical cord, I need to keep pressures higher. I'm going to keep my NORAD running on a peripheral dose, 2 in 50 at 4 or 5 ml per hour. I'm going to keep that on. Okay, NORAD. I'm going to keep IV fluids at full flow. IV fluids. I'm going to secure that I got 2 nice IV lines. Okay, 2 nice IV lines above the range of 20, 18 or something like that. One giving IV fluids and the other in which NORAD is going on. Clear on this? Clear till now? So IV fluids has to be fast, NORAD is very essential. So what did I say? I pre-oxygenated a patient with 100% of oxygen. I gave them IV fluids running fast and noradrenaline at a very small dose. We kept that on. We have to keep that on at every case. What are the drugs you will keep ready? You will keep ready everything which includes etomidate, ketamine, propofol, fortrin fentanyl, and adrenaline and epinephrine. Adrenaline and phenylephrine. Now which drug do you use for what? If you want to intubate, you cannot just intubate patient conscious. Usko agar intubate karna ho, even if he's upturned, you need to give some pain relief. What do you use? So if this patient, so the question is what is happening to this patient depending on that. So if the patient is hypotensive, which will be 75% of your cases, because those patients who've got polytrauma and come hypotensive, it is hemorrhagic shock unless proved otherwise. It is hemorrhagic shock unless proved otherwise. Clear? If a person who is coming with polytrauma, 70% of the times that is what will be your case is going to be. If it's going to be like that, then it is hemorrhagic shock. It is hemorrhagic shock. So in hemorrhagic shock, the drug of choice I will use during intubation period is going to be ketamine. Okay, it's going to be ketamine because it preserves my my blood pressure. But you can also use etomidate. You can also use etomidate. So etomidate gives you an element of cardiovascular stability, which you can use. So etomidate is something that you can use in such cases because it gives you cardiovascular stability. Clear on this? Gives you cardiovascular. If the patient's BP is normal, pulse is normal, propofol also you can give. If everything is normal, you can give propofol also. Okay, but that is only if there is no shock, if there is no bradycardia. If there is cardiovascular instability, the drug of choice remains etomidate. Otherwise, ketamine. Clear on this? Ketamine has got the dual advantage of A being an anesthetic, B being an analgesic. It's got the dual advantage. It's got analgesic as well as anesthetic capabilities. So it actually works quite well in such cases. Clear? There is no danger of raised ICP in such cases. Okay, you can actually give ketamine, no problem per se. Clear now? Am I clear? Clear on the drug? Depending on what you are dealing with, you can actually use a paralytic, either scoline, succinylcholine, or you can use rocuronium. Okay, I'm not going to use antracurium, I'm not going to use becuronium because they take a long time. So it's going to be either rocuronium for rapid sequence intubation or it's going to be succinylcholine. There is no, if it is very late after trauma, then I will not use succinylcholine because it is known to cause hyperkalemia in such cases. If it's very late after trauma, maybe 2 दिन 3 दिन की बात हम कर रहे हैं, then maybe I may not use choline, I may use rocuronium. Clear on this? So I understood the pre-intubation drugs that I'm keeping ready. I'm keeping a double dose push dose adrenaline ready. I'm keeping my IV fluids ready. I'm keeping etomidate ready, a propofol ready, ketamine, as well as I'm going to keep my fentanyl ready. Okay, pain relief is very essential here. Clear? Clear on this till now? Clear? Now the question is, I am coming to the act of actual intubation. I put my IV fluid on. I've given my scoline. A patient has gone under anesthesia. What is my next step? My next step is remove the collar. If it's a Philadelphia collar, no problem. Just remove the anterior part of the collar. If it is a patient with a hard collar, you have to remove that collar because you can't intubate with that collar. The collar ke saath intubate, laryngoscope will not go inside because the mouth will not open much. Clear on this? It's very difficult for the mouth to open in such cases. So I'll have to remove my cervical collar. But when I'm removing it, I'll be very careful. I need the second operator here. The first of all, who's going to be the intubating person? The most experienced person in the room will be the person who's going to intubate this person. The most experienced person. It's very essential. Most experienced person you're going to be intubating. Okay, number one. Before my intubation, I need to keep certain equipments ready. And what are those equipments? My equipments remain a video laryngoscope. And why the video laryngoscope? Not because it makes intubation simple. It's just that you may be able to see it much more easier. Okay, video laryngoscope. A bougie, a stillet, a supraglottic airway if you cannot intubate. That means LMA. Okay, LMA. Okay, and a percutaneous set ready. These have to be ready. You cannot go and intubate this patient without all of these things, which includes the usual thing, EtCO2, tube, and laryngoscope. It includes those things. Clear? That is anyways there. Clear on this? Clear on this? Now how do I go for the actual intubation? For the actual intubation, I have to ensure first that the patient is at level of my umbilicus. If I am the person who's operating and I am the senior most person in the room, I am going to be on the head end, and I am going to standing on the head end with the table at my umbilicus. I can't put a head ring. I can't do all of those things. What I'm going to do over here, the moment the patient is under anesthesia, immediately, how do I check under anesthesia? I look with the eyes, I see whether there is eyelash reflex over there. Okay, once that is happening, the next thing is I remove the cervical collar and I tell the operator, second operator, to either stand there or stand here and hold the spine. That is called as manual inline axial stabilization. That means the person, if is standing here, if the body is lying like this, I can stand down here, and I can hold the mastoid process like this. You're getting the point? It has to be done that way. It cannot be, there is no other method to do this. Okay, so you are supposed to stand here. This is where the stretcher is lying. This is where the patient is. On the head end, there is the operator who's going to intubate this patient. The other person is going to stand down here, hold the mastoid process. I'm holding the mastoid process as well as the neck. I'm not pulling, not pushing, not doing any of those. My hand is standing on the shoulder. Or the other ways, you stand on the left of the patient, on the right of the intubator, the person who's intubating, and hold it like this. Okay, right like this. With this will hold the shoulder, and that will hold the mastoid process. This is called manual inline axial stabilization. Manual inline axial stabilization. So if anyone asks you how I'm going to intubate, the first thing should be MILS. Okay, manual inline axial stabilization. So in manual inline axial stabilization, what am I trying to do? I'm just trying to ensure that it remains in the same axis. I'm just ensuring the spine remains in the same axis. Clear? Then the next step is, after giving the scoline, is to actually put the laryngoscope inside and without any manipulation, pass in the tube. Okay, whatever gives you the first pass success. So someone might say, मेरे को video laryngoscopy में problem होता है, तुम मत करो video laryngoscopy. You're comfortable laryngoscope, use a laryngoscope, comfortable bougie, use a bougie. But use the most comfortable technique that you can. What we know is that video laryngoscopy gives the best first pass success as of now. That is now we know. The new data says video laryngoscopy gives us the first pass success. But if you don't have video laryngoscopy, use of a bougie gives you first pass success. Okay, if you don't want to use video laryngoscopy, use of a bougie gives you first pass success. So I would immediately do my laryngoscopy, put the bougie, secure the tube, and look for EtCO2. Clear on this? When I'm doing the scoring, when I'm giving the propofol, one of the dangers that occur with these cases is the fact that they will have bradycardia and hypotension, extreme bradycardia, extreme hypotension. So the usual doses don't work. They will give very high doses of adrenaline, very high of phenylephrine, things like that. So adrenaline, the 1 milligram adrenaline you'll have to give, okay, or something like that you'll have to give at that stages. समझ में आ रहा है? I intubate and secure the airway. Now somebody might ask, then why not we just do flexible bronchoscopy? Okay, you have bronchoscopes you can just put in and you can pass the tube in through. No, but you can't do it in trauma cases. What happens in trauma cases is the fact that for a flexible bronchoscopy in awake intubation, there's a lot of blood inside. So when there's a lot of blood inside, putting the flexible bronchoscope becomes a hazard. Very difficult to do that because the blood itself obscures the airway. You can't see anything inside. Are you getting the point? So it's not a great thing to do when you have a trauma patient. The flexible bronchoscopy becomes a big problem. The only thing that, but if there's a patient who's very sedate, very normal, sitting in front of you normally, and there is no big trauma, just a cervical spine, you may want to attempt a awake intubation with a fiber optic endoscopy, fiber optic scopy. समझ में आ रहा है? Huh? But as far as possible, we will not be in that condition. We will be in a condition where we will be going ahead and doing a direct laryngoscopy under vision. Under vision. Okay, securing the airway doesn't complete over there. After securing the airway, it's important for us because now the manual inner action stabilization is still going on. At that moment, after you have secured the airway, after putting the tube through, you have tied the tube. After you have tied the tube, the manual inner action stabilization is still going on. So you now remove the manual only after you have put back the cervical collar. After you put back the cervical collar. So the next step after that is post-intubation, is to ensure that the ET suit is normal, the BP is normal, the pulse is normal, and you have put back the cervical collar. In a person in which you are sedating, you don't need the cervical collar. In the patient whom you are sedated, paralyzed, kept them sedated, you don't want to paralyze such patient, but if kept them sedated and hardly any movement, for that matter, you can just keep two head rings, boards besides, two boxes besides, and immobilize. It's called as a cervical head immobilizer. You just put the head immobilizer and you tape the head. That is enough. Head immobilizer is enough. In a person who's hardly moving, nothing like that, a head immobilizer. Because why? A spinal collar, if you put it, to remove it, you have to think fast. Because a spinal collar, a hard cervical spinal collar, any of those collars can cause pressure injuries, can cause pressure ulcers. Putting lines becomes difficult. The jugular line has to come from inside somewhere. You understand? All that becomes a problem, when you have a spinal collar that is in place. You get the point? So, importantly, post-intubation, it is important to actually again stabilize the spine with either blocks, a cervical spine immobilizer, or a cervical collar. Remember this, when a person comes from road traffic accident, he is already on a spinal board. One of the most dangerous things is a spinal board. A spinal board, have you seen a spinal board? It's that hard board, red color, yellow color, जो hard board होता है, जिसमें holes होते हैं, जिसमें पकड़ सकते हैं, ठीक है? The spinal board is one of the most dangerous things because it's very hard. It is really really hard, पत्थर जैसा है वो, ठीक है? तो उसके ऊपर अगर बैठेंगे ना, उसके ऊपर अगर रहेगा तो प्रेशर सोर्स होना ही है, तो spinal board को निकालना बहुत ज़्यादा ज़रूरी है. When a person, so normally the sequence is patient comes on a spinal board, you have first secured the airway, then you have immobilized the cervical spine, then you remove the spinal board. ये ऐसा होता है because you have to log roll. You have to log roll these patients. So when you're removing these things and all, you need to log roll. What means a log roll? The whole body is taken as a unit. So there are people who are taking care of the spine, there are people taking care of the shoulder, here of the legs. So the whole person is moved as a unit, back and forth, as a unit. So this is all about spinal immobilization. Spinal immobilization. Any queries on this?